Good evening. Today we are here for a very interesting discussion by Dr. Vimarshani Hewageegana, who is a third year registrar in family medicine. And she is also a lecturer in family medicine in the Department of Family Medicine, University of Colombo. So today's presentation is themed to go or not to go. A very common but topic, but we are not talking about it much. So not discussed. So I would like to introduce our Madam Dr. Lalanta Senaratna also to the occasion. She always guides us throughout the presentation. And to start the presentation, I will hand over the mic to Dr. Vimarshani. Over to you, Vimarshani.
Thank you very much, Dr. Prabhat. So today I'm going to center this discussion on a young girl who I encountered at the Family Practice Center, University of California. For the purpose of this discussion, we'll call her Miss K. So Miss K came to me with her parents with a problem of refusing to go to school for the past 10 months. So this all started 10 months back when she went on a school trip and she woke up in the dark inside the school bus parked on the beach. She looked outside, her friends were singing and dancing outside, and she felt a sense of panic. She detailed a very stereotypical panic attack with intense feelings of fear, palpitations, and choking sensation. So, according to her, after this incident, she has refused to go to school here and there, but she had not had any further panic attacks. So, for the 2 weeks prior to the encounter with me, she has refused to attend school entirely. So she described her feelings when inquired. She described her feelings as an intense fear of having to see and interact with her teachers and friends. She was very scared of being scrutinized and looked down on by her peers. Although she understood that the fear was not logical and it's unfounded, at the same time, she was not able to control it. So she used the phrases Mata monohari vei and Mama monohari karai to explain her feelings. So prior to this, she was a very good student. She was very helpful to her friends. She even brought friends back home with her to tutor them in maths. But she claims in her time of need, when she was lagging behind in school, her friends did not reciprocate that loyalty and friendship, and they were being quite selfish and unwilling to help her. She was also very hard on herself. She was feeling guilty and she was blaming herself for not being able to go to school and performing rather poorly. And subjectively or objectively, there were no other odd or unusual behaviors on her part. Approach. I'm sure we're all familiar with the HEADS approach. It's an instrument, it's an interview instrument used, developed in 1991 to sort of bring out all the issues that adolescents face. So this is a clinical tool that we use quite commonly in our practice when we encounter adolescents. So that is a tool that I applied with Miss K. So H stands for the home environment. So she's an only child to a stay-at-home mother and a clerk. She had a really good relationship with her parents. Even after all this happened, she remained to have a very good relationship with her parents. There were no family conflicts, and the parents, according to her, and the parents themselves did not put any pressure on her to perform. Rather, it was the patient who was putting a lot of pressure on herself and being very hard on herself. So objectively also, I could detect that there was excellent family support. I was able to interview this child and the parents separately, and they all of them claim to have a very good family environment at home. So E stands for education and employment. So Miss K was a high-performing student before all of this happened. She was very good at maths. She had an excellent relationship with teachers. She has never gotten into trouble at home. But recently she has started to lag behind in her work and her grades have started to drop. So activities. She used to be engaged in the literary society at the school, and she used to be an athlete who ran competitively. She also read for pleasure. She was a happy child. Her pre-morbid personality was quite a normal one. Now, all of this has changed. She had very little interest in recreational activities. She had very little hope going forward, and she claimed to have very few close friends and was not willing to talk about her friends at all. So, D for drugs. She denies any substance abuse either by her or her peers. Her father is a non-smoker and she was not exposed to any kind of substance abuse, either recreation, drugs, smoking, or alcohol. So, sexuality and sex. She admitted being attracted to the opposite sex, but denied having any romantic or sexual relationships at present or in the past. She did not seem conflicted about her sexuality, and she very strongly denied any history of sexual abuse at school or home. So the last S is for suicide and sleep. So she appeared quite depressed at the initial presentation. She was very depressed. She claimed to have very poor sleep, very poor appetite, and she felt very hopeless, and she had a very dark outlook on life. She had passive and sometimes active suicidal ideation, but no active attempts on her life. So this was a girl who, like I said, based her entire personality on being a good student, on a studious and being a good child. So she was feeling very dark, and she was in a very low point when we saw her. So I started to think about what could possibly be going on. So just to see whether my line of thinking aligns with everyone who is here. Can you guys help me out with a few differential diagnoses for this patient? Any ideas?
Anxiety disorder.
Yeah, so that is one of the diagnoses that were very high up in my differentials as well. Anything else?
Depression.
Yes, again, another one of my differentials. I'm sorry? Yeah, so I thought of a few differentials. First thing was I wanted to rule out any physical causes for this school refusal. She denied any chronic pain or any skin ailments which would have made her self-conscious. She didn't suffer from any bad acne or undue hair growth or anything like that. Her menstruation was quite normal. Her periods were regular. She didn't suffer from period poverty. She came from a family with good family support, and their financials were good. She was a healthy weight and height. She was not at all concerned about her appearance. So I was able to rule out most of the most common physical causes for school refusal. So my second differential was generalized anxiety disorder or agoraphobia. She did not have any other causes of anxiety. She did not worry about her health. She didn't worry about something bad happening to her or her family. So, and she did not have trouble going anywhere other than her school. She was going shopping with her mother. She was, traveling by herself in public buses. She came to see me in a public bus. So I didn't really find anything that would fit a GAD or an agoraphobia diagnosis. So the next thing I thought about was a panic disorder, because she came with an initial panic attack and she was terrified of having another panic attack, which are two hallmark features of a panic disorder. But she has only ever had one panic attack. So that was, I was not very convinced that she was having a panic disorder. So the other differential I considered was whether she was having a budding personality disorder like schizoid personality or a paranoid personality, because she lacked close friends and confidants. But on the positive side, she was very emotional. Even when she was talking to us, she was very emotional. She was not cold and aloof. She used to engage in group activities. She used to enjoy friendships. She used to go out and have fun. So this does, her pre-morbid personality seemed to be quite normal. Although she believed her friends are sort of exploiting her and not returning her loyalty, and her teachers don't like her, she didn't really fit the diagnosis of a personality disorder, also, especially because she was still 15 years old and too young to be diagnosed with a personality disorder anyway. So, my next differential was social phobia. So she fit the criteria for social phobia. She has intense fear of scrutiny by her peers. She had fear of doing something inappropriate, and she was avoiding. So this was having significant functional impairment, and she was in significant distress because of it. And all of this has been going on for more than 6 months. So that was my leading uh, thought at that point. So she also qualified for a diagnosis of depressive disorder. She had subjectively and objectively, her mood was very low. She has anhedonia and she felt extremely hopeless, had a very dark outlook of life. She had very poor appetite and very poor sleep. She had very early morning awakening. She woke up at about 2 or 3 in the morning and stayed up all day because she was not able to fall back to sleep. So she had, like I said earlier, she had passive and active suicidal ideation, although there were no attempts that she admitted to, at least, and there was significant functional impairment. So the other diagnosis, the differential diagnosis I considered, was early onset schizophrenia. This was considered because she had some concerning symptoms of schizophrenia that can be present in a young adult. So she was very nervous. Even at presentation, even when she was talking to me, she appeared quite nervous and very restless. She was clinically depressed, and she admitted to being anxious. And she had, like I said, very low self-confidence at that point. And she was withdrawn from her friends, withdrawn from her teachers, and her only support system seemed to be her parents at this point. So that was one of my concerns. So thinking about all this, we finally tentatively thought she probably had social phobia with comorbid depression. So what did we do? We, along with our consultant at the family practice center, we made a same-day referral for her to be seen by a consultant child and adolescent psychiatrist. Quite interestingly and quite disappointingly, actually, later on in the same day, I actually followed up with her purely out of academic interest to see whether she has been started on any drugs, whether she has been referred to any CBT, what has happened. But then the father quite tearfully told me that despite a referral highlighting suicidal ideation and school refusal, she was seen by an MO, not seen by the consultant, not given any drugs, not referred for any kind of counseling, and just given a clinic date 4 months later. So this is a child who has already lost 10 months of school, and 4 more months would have been quite catastrophic. So we brought her down immediately the next day, and we were able to arrange an inward referral with the consultant adolescent psychiatrist the same day, who saw her and took a very good comprehensive history, sat and talked to her for a long time, and referred her for cognitive behavioral therapy, and started her on an SSRI, sertraline 25 milligram mane, and quetiapine, Nocte. So we also discussed the possible side effects of SSRIs like suicidal ideation and gastric disturbances. And because she wanted to get back to school as soon as possible, we talked about the sedative effects of quetiapine and all that. So before we talk about what happened to Miss K, let's talk a little bit about school refusal. So school refusal is a child psychiatric emergency. That is the reason we referred her same day to be seen by a consultant psychiatrist. So only about a third of children who miss school for a prolonged period of time will ever return to complete their education. So quite understandably, this significantly increases their risk of developing antisocial traits, illicit behaviors, and in cases of teenage girls like Miss K, the risk of teenage pregnancies. So all this puts a lot of economic burden on the society, on you and me, and causes a lot of personal distress for these children and their families. So the definition of school refusal is a bit of a mouthful, but the definition is a school-aged child who has missed at least 25% of the school time over the last 2 weeks and has difficulty attending school for the last 2 weeks, such that significant interference occurs in the child's or the family's daily life. So she fit this criteria almost to the dot. And the definition also includes children who are absent for at least 10 days of school during any 15-week period while school is in session. So according to this definition, Miss K we could diagnose this child with school refusal, although school refusal itself is not a diagnosis. So this is something 1 to 2% of school-aged children experience, and this 5% of all clinic referred children experience school refusal. There are 2 peaks, 5 to 6 years when children initially start schooling, and later on at about 10 to 11 years of age. So this is equally prevalent among girls and boys. Like I said, this is not a syndrome or a diagnosis per se, but a symptom of a larger problem. So about 50% of children who presented with school refusal was ultimately diagnosed to have some kind of an anxiety disorder. About a quarter of them had a depressive disorder, and the rest had a mix of a depressive and an anxiety disorder. So if we go down to the commonest specific causes, the commonest cause was actually separation anxiety disorder in the first peak, the 5 to 6 year peak. These are very young children who are still just starting to school, who know nothing outside of their own parents. That is the biggest chunk. Then you have cases like causes like social phobia, which make up about a third of the cases, and then simple phobias, which make up about another quarter of the cases. So the rest of this is made up of rarer causes like opposition and defiance disorder. So it is very important to be able to differentiate school refusal from truancy. So children who experience school refusal suffer severe emotional distress when they think about attending school, which is not really seen in truant children. So when a child experiences school refusal, the parents are aware that the child stays at home, and although hesitantly, they stay at home with the parents' permission, and the child stays at home during school hours. Whereas in truancy, the child tends to conceal their absence from the parents. These are the runaways, and these are the what we call the kattipanina students who don't stay at home, who don't go to school, who engage in other delinquent behaviors during the school hours. So school refusal is not really associated with a significant amount of antisocial behaviors like oppositional defiance disorder, whereas truancy is very commonly associated with these destructive, violent, and harmful behaviors. So these truant children are actually a large proportion of them go on to develop antisocial personality disorders, and they tend to become violent later on in life. Whereas children with school refusal, they have a very poor prognosis when it comes to academic activities, but they are not shown to become violent or delinquent later in life any more than the rest of the population. So how do we manage school refusal? Obviously, because it is not a syndrome by itself, we need to treat the root cause of the problem. The first line pharmacological management is usually by an SSRI. First line is actually sertraline. A lot of us would be surprised by this because we know fluoxetine is known to be the only antidepressant that has been tested in young adolescents. But in this case, because this is usually an anxiety disorder, sertraline is actually the first line used in the guidelines. So Miss K was also started on sertraline 25, but we can actually go up to about 200 milligram daily. So they can also be given a short course of benzodiazepines like lorazepam and clonazepam. But the risk with benzodiazepines is obviously it's quite habit forming, and they have been associated with cognitive impairment if they are used for a prolonged duration. So they should never be given more than 4 weeks unless there's a very clear indication. But if the sleep is disturbed, like in the case of Miss K, and if they have significant anxiety that is impairing their daily activities, we can consider a short course of BDCs. So cognitive behavioral therapy is very commonly practiced, where these students are taught to look at problems differently, to handle situations in a more productive way. And also dialectical behavioral therapy, I'm sure you know, that is usually given to personality disorders, where they are taught to be mindful, and they are taught to adapt to change. So we also can teach them relaxation exercises if they have anxiety, generalized anxiety disorder, specific phobias, and obviously they need social skills training. So all these CBT and these DBT, CBT, all this is done in a graded way, and the child is exposed to the situation that is causing them anxiety very gradually. So coming back to Miss K, a week later, I followed up with her to see how she was doing. She had good compliance with drugs. She had very good family support, so she was being very careful with her drugs. She did not experience significant side effects like increased suicidal ideation or any gastric disturbances. But she has only attended school 1 day in the preceding week, so she was not feeling very hopeful. So 2 weeks later, however, she has managed to attend all 5 days of school. She still reported some level of anxiety. She didn't have any panic attacks, which she was very fearful of having if she ever returned to school. She still didn't report any increased suicidal ideation, and she was not really reporting any active suicidal ideation at this point. And she was starting to become optimistic because she has been able to attend school all 5 days and stay throughout the school time without having to come back home. So these are just snippets of conversations that I had with her 3 months later and a year later. She was weaned off her quetiapine after a month. She's still on her sertraline a year later. So she has successfully sat for her ordinary levels and awaiting results, and she's hoping to do her A-levels in commerce stream. So this is a feat she thought would not be achieved when I saw her. So this initial consultation was in November of last year. So at that point, this seemed like quite an unachievable goal. So I think this is a success story because we were able to refer her promptly and get her the help she needed. But like I said, a lot of the children who experience these difficulties might get left behind if we don't follow up with them. That is, I think, as family physicians, that is under our purview to do, because these are patients and not just a number in the queue for us. So what more is there to do for Ms. K? It's very important to follow up regularly. She is on regular follow-up at the Child and Adolescent Psychiatric Clinic at IT Center. It's very important to make sure that she has good compliance, and very important to keep an eye on her on the side effects of drugs, and to see whether she's evolving. She's in the process of an evolving disease like schizophrenia or a personality disorder. So it's also important to keep in touch with her teachers and friends and peers to get a third party opinion, because this is still a young child, and it is with suicidal ideation, which puts her at a very high risk. So it's always very important and prudent to keep in touch with not just her, but her carers as well. So that is actually that is the discussion that I wanted to have about this. I thought it was a very interesting encounter, because school refusal is not something that we talk about a lot, but it is a bigger problem that we consider it to be. So do you think that I've missed anything in the differentials? Because the reason I followed her up for so long is because I always had this nagging feeling that I might have missed something. So I would really like your opinion on whether you think I should have thought of something else, or whether there is anything else in the management that I should have thought about.
Vimarshani, you have
Yeah.
done a really great thing there. I think it's like uh, really good lesson for us also. I wanted to know whether you have involved the teachers or the
Yeah.
the school for this management.
Yes, doctor. So that is something that I actually asked her and asked her parents also. She had a very negative outlook on her teachers at the initial point, so she didn't want me to contact the teachers at all. So later on, when she was sort of she was feeling a bit optimistic, I offered again to talk to her teachers and maybe discuss what is going on with her teachers. But then again, I think because of the social taboos that comes with psychiatric disorders, her and her family, all of them didn't really want me to talk about her diagnosis or her management with the teachers. So that is something I was not able to do for her, but it's something that I mean, ideally should have been done. Yes. I think that is all. In that case,
Dr. Vimarshani,
yes.
how long you should continue this treatment? Certainly.
So, so she was actually, I forgot to tell you, she was actually formally diagnosed with social phobia also. She told me over the phone that she was diagnosed to have social anxiety, in her words. So in case of social anxiety or social phobia, it's necessary to continue. If you find a successful SSRI, we have to continue it for at least 1 year. For an anxiety disorder. Unlike in depression, for the first episode of anxiety, we have to continue it for at least a year. So she's still on sertraline, almost a year after the initial encounter.
After the year, you can reduce the doses.
Yes, we have to taper it off and see how she does.
Yeah, thank you.
Just one question. Since you also had suicidal ideas, is there anything apart from SSRI that we can consider? Because
So usually,
sometimes SSRI, they say, can increase suicidal
yes,
ideation
yes.
in adolescents.
Yeah, very correct. So that is why we were concerned when she was started on sertraline also. So that is the reason we followed her up so closely to see whether she was having any adverse effects. So usually any patient who's coming with suicidal ideation, we usually admit for observation. That is the reason we made a same day referral. But the child and adolescent psychiatrist talked to her and determined that she had a very good support system at home, and she had a good, we did a lot of safety netting with her and the parents also. So we talked about the possible side effects, possible adverse feelings of increased suicidal ideation that comes with SSRI. But this is a bit of a tough case to manage. So I believe the reason she was started on sertraline is it is a first line, and it's proven to be very, very effective in this case.
Thank you.
Hello, Vimarshani.
Yes, madam.
Now tell me the duration for the whole story. I mean, according to your description about the patient,
Yes, madam.
what I understood was that all of a sudden, while he was, that traveling or he was in a trip,
Yeah.
all of a sudden, he or she developed this thing, isn't it?
Yes, madam. Initial panic
You know,
attack followed by the
it's just a bit of a, like, I don't know whether this is, of course, the very first attack, or he or she, of course, didn't tell the whole story. Because
yes.
now, like the very, first with just one episode like that, I think it does not tally with the social phobia.
Yes, madam.
Right? That is one thing. The second thing, why the person developed it, as I mentioned earlier also for you all, the 3 P's: precipitating, predisposing, and perpetual. So how do you give those description for those 3 P's?
Yes, madam. So that is first we thought this was a panic disorder because it started with an initial panic attack. So we really thought she didn't fit
Yeah, but I'm sorry, you didn't get my point. What I'm asking is, those with the diagnosis, whether it's a social phobia, the panic attack, or depression, or whatever. So whatever the diagnosis, we must have some 3 P's. Why?
Yes.
The predisposing factors. I think you can remember the things I've told earlier.
Yes.
The second thing is predisposing, precipitating, as well as perpetual factors, right? So then, accordingly, what do you think about? So, did you try to find what are the precipitating and all these things, all the factors?
Yes, madam. She was actually in the initial consultation. She was very reluctant to give a detailed history. I had to dig very deep to get what I actually took out of her. I could not, to be really honest, I could not find any precipitating factor other than this sudden onset fear during the trip, because she had.
Yeah, but because he was looking outside.
Yes.
Was it something happened?
Yeah, so that is
very important.
Yes, so we really dug very deep into it and asked whether she encountered any kind of inappropriate touching, any sexual abuse while she was in the bus alone. She was with a guardian, a female guardian. All the students were outside, but a mother, one of the mothers of the group, had stayed behind because she has fallen asleep in the bus. So she vehemently denied any negative experience from a third party. So we actually thought there must have been something that she's either hiding intentionally or unintentionally, or she's shutting out, which is still possible, that she either doesn't recall or she's not willing to tell us that something happened during this trip.
Yeah, or else it could be the patient or the baby, the child had similar, maybe similar, or like sort of some episodes like that either earlier as well, because it's some sort of all of a sudden, if it happens, it's very, it's very unclear, and it's just, we cannot say it's social phobia. The description of the social phobia is a little bit different, isn't it?
Yes, madam.
It's gradual onset, and they have this and that. There's step by step, the progressiveness is very, like, the earlier, the very subtle features and something like that.
Yes.
This is all of a sudden the patient develop all these things.
Yes.
And
so
this, of course, is awkward, isn't it?
Yes, madam. So she has actually, after this initial incident, she has only missed sporadic days of school. She was still going to school, trying to get on with her work. Her symptoms have actually been quite progressive over that 10 months. So whether she is attributing her symptoms to this incident, which has nothing to do,
Yeah,
it is
could
possible
be.
that she is maybe either misremembering or attributing this change of her behavior and feelings to that particular incident. So her symptoms have been quite gradual in onset and progressive over that 10 months. And only within the 2 weeks preceding the encounter with me has she completely stopped going to school because of the severe anxiety. Until then, she has at least attempted to go to school, attempted to engage with her friends, but then started to develop this severe anxiety about being criticized and looked down on by the teachers and her friends.
Yeah. Okay, but the rest of the things, of course, like we can understand. But the very first initial, the
Yes.
rapid, all of a sudden, like it's just.
Yes, yeah. So that was the point that we couldn't really reconcile with the rest of the history. So I brought her down a couple of more times and asked her personally whether there was something. Once I built a good rapport with her, I asked her whether there is anything more she wanted to tell me. But she repeatedly denied any physical, emotional, or psychological abuse from the family or anything she thought might have triggered this. So, yeah. So the final diagnosis given by the consultant child and adolescent psychiatrist was social anxiety disorder, and she was treated as such also.
Okay, and the other thing, the third thing, that you want to do the very first time, the social, the refusal of school refusal is a big issue, and you wanted to send the person for the maybe psychiatric unit or whatever. But if you think that is the like particular, we do not know what had happened in the hospital the very first time. The medical officers, they saw the person and then gave the date in 4 months' time, right? But
Yes.
anyway, but I think there, in this scenario, if you really want to get the like immediate sort of a support from the psychiatric colleagues, what I think is because that what I'm doing, we have to talk to the psychiatrist directly, or we have to write to a particular, the name. Otherwise, to send the person to just a hospital. The thing is, maybe the way they give dates is the same, right? So that's the thing. So they do not know which, right? There's no sort of a like they either triage or whatever the things in those clinics are there. So because of that, they as a routine way they give. But if you think that it's a very urgent matter, so get the urgent sort of a assessment by the psychiatrist colleague, what you have to do is, straight away you can talk to them, or else give a referral to a particular person. Then
Agreed. Yes, ma'am. Agreed. We actually gave a written referral to Professor Chandradas at the time, but he's a very busy person, so the child was not even he was not able to see the child on the day. But I agree that we could have made a better attempt to contact him in
Okay, right. So it's a very good eye-opening like session for everybody. It's a very, I think though you got this patient from Kalani, I think you have seen maybe more than 15 patients like that.
Yes.
The appointment with me.
Yeah. So I was able to sort of diagnose more of them once I was aware of this condition, because I didn't really know that this was such a big issue and so prevalent. But yes, madam, yeah.
Okay, then. So if you don't have anyways, thank you very much for a nice, very comprehensive presentation with the all sort of descriptions about these school phobias and all. And questions about the others? If not, we'll wind up.
Okay, madam. Thank you very much.
Thank you very much, Vimarshani, for that very informative presentation. And I would like to thank Madam Lalanta Senaratne for commenting and even correcting us and guiding us throughout the presentation and during our registrar period for 3 years, for more than 3 years now. Thank you very much, Madam. And
Thank
good
you.
night, everyone.
Thank you.